endoscopic resection of TIS, that is, carcinoma in situ colorectal cancer, is accepted as a curative therapy because this lesion carries no risk of lymph node metastasis. Endoscopic resection has been utilized recently to treat patients with T1 colorectal cancer. Are there any limitations to its use? Lymph node metastasis has been reported to occur in 7 to 15% of T1 colorectal cancer cases involving tumor invasion of the submucosa. This suggests caution in the use of endoscopic resection for T1 colorectal cancer. Knowledge of histopathological features that would indicate the possible presence of lymph node metastasis in T1 colorectal cancer would be highly helpful in decision-making about a treatment of T1 colorectal cancer with endoscopic resection. Deep submucosal invasion, angiolymphatic invasion, and grade 3 have been reported to be associated with lymph node metastasis in T1 colorectal cancer. Some researchers have demonstrated that budding, also known as sprouting, defined as isolated cancer cells at the margin in the otherwise normal tissue, is one of the histological patterns of cancer growth and is significantly associated with lymph node metastasis in colorectal cancer. Background adenoma, also known as pre-existing adenoma, is defined as benign adenomatous tissue contiguous to resected carcinomas. In relation to the adenoma-carcinoma sequence, a background adenoma may be the original adenoma from which the carcinoma originated. Some colorectal cancers, however, are not accompanied by background adenoma. The absence of background adenoma in the tumor has been considered a histological criterion of de novo cancers. In the recent issue of Endoscopy, Su et al. Seek to identify the histopathological factors of colorectal cancers associated with lymph node metastasis in T1 colorectal cancer. In their paper entitled "The Predictors for Node Metastasis in T1 Colorectal Cancer, Grade 3, Angiolymphatic Invasion, Budding, and the Absence of Background Adenoma," this is what they report. It is critical that the risk of lymph node metastasis is evaluated for determining the suitability of endoscopic resection for T1 colorectal cancer. Reported risk factors for lymph node metastasis in completely resected T1 colorectal cancers are deep submucosal invasion, grade 3, angiolymphatic invasion, and budding. The aim of the present study was to identify the histopathologic factors associated with lymph node metastasis in T1 colorectal cancer. The study involved 435 patients with T1 colorectal cancer treated by endoscopic or surgical resection between January 2001 and April 2010 at the National Cancer Center, Korea. The 435 patients were classified into two groups: those undergoing surgical resection, N324, and those undergoing endoscopic resection, N equals 111. In the surgically resected group, details regarding depth of submucosal invasion, angiolymphatic invasion, tumor grade, budding, and background adenoma were evaluated with respect to the presence or absence of lymph node metastases. In the endoscopically resected group, the results of follow-ups and additional salvage surgeries were studied. In the surgically resected group, lymph node metastasis was detected in 42 patients, 13%. Grade 3 angiolymphatic invasion, budding, and the absence of background adenoma were identified as factors associated with lymph node metastasis in univariate and multivariate analyses. P-value less than 0.05. Among the 50 patients in the endoscopically resected group with high risk, 3 were diagnosed as being lymph node metastasis positive during the follow-up period. There was no lymph node metastasis in the endoscopically resected group with low risk. The authors conclude that grade 3 angiolymphatic invasion, budding, and the absence of background adenoma are the risk factors that predict lymph node metastasis in patients with T1 colorectal cancer. In cases where endoscopically resected T1 colorectal cancer has no risk factor, cautious follow-up could be recommended. However, if the tumor has any risk factor, additional surgical resection should be considered.